Okay, well, I hope everybody's doing well. Thanks again for being here. I hope everybody's healthy and doing well. I will apologize in advance if I start to cough. It is a little bit smoky here in Colorado, and even though I'm not using an evidence-based strategy and throat lozenges, hopefully it'll um, keep me from interrupting the talk today. So, excuse me. What I'd like to do is start off, excuse me, with a scenario. It's not one that I'm wishing on any of you, but let's say you go to your doctor, excuse me, you have a fever, 103.4, you receive an injection of penicillin and a penicillin prescription. 24 hours later, your temperature is 100.2. So the question is, did the penicillin treat the disease and reduce your fever? So we have three options here. One, yes, you believe that the penicillin cured you. No, that the penicillin was not of value. And for those of you that are convinced that I'm up to no good if I'm starting off a talk with a quiz, you don't have to commit either way. So Samuel put up the poll. If you can go ahead and vote, and we'll see what people think about this. Okay, looks like I've got some trust issues. Most of you don't trust me here. And then for everybody else, it's pretty evenly divided in terms of yes or no. The answer is, in my opinion, maybe and maybe not. Could be the penicillin took care of whatever was reducing your fever, but it could be that even if you hadn't taken the penicillin, your fever might have gone down anyway. Let's say it was some sort of viral infection, and it would have quickly resolved on its own. So to figure that out, a lot of times we need a lot of ancillary data to figure out what's going on. So why don't we go ahead and modify this question a little bit here. And you go to you have the fever, you receive an injection of penicillin, your temperature is 100.2 24 hours later. And then all of a sudden, excuse me, also, you also have a COVID-19 test. And then 4 days later, the results come back and it says you're positive. So the question that some people may throw out is, did the penicillin cure that COVID-19? Probably not, because penicillin is more active for bacterial infections, and COVID-19 is a virus. Wouldn't be the first time that a drug had unintended or unanticipated benefits. But the reality is that it probably was not of any value. And for those that think that the penicillin cured them of their COVID-19, they're probably not entirely right there. So, oh, I'm sorry, I didn't move that ahead quick enough. So anyway, so these sorts of scenarios are what hopefully illustrate the challenges that go along with evidence-based medicine and why it's important. So some of the topics that we'll be going over: one, what is evidence-based medicine? Two, how did we get here? What's the history in terms of why evidence-based medicine came to be? And then what types of clinical research and confidence can we have to support evidence-based medicine? And I've got that in bold and underlined because that's pretty much going to be the emphasis of what we're going to be talking about here. But there are other elements of evidence-based medicine. Then we're talking a little bit about outcomes as well, which we just went over with our scenarios in terms of the fever going down, and hopefully you're feeling better at that point. It's not the holy grail for everything, so we'll also be talking a little bit about some of the criticisms of evidence-based medicine as well. So, what is evidence-based medicine? This definition from NASIC is the one that I really like, because it emphasizes that not only is it conscientious and reasonable use of the best available medicine, but it's also explicit and judicious, meaning you're pretty upfront in terms of not hiding what sort of biases you may have in mind. So what I'd like you to do is burn this image that I just brought up in your mind, because even though I'm going to be emphasizing the science, and hopefully you guys can see my cursor there, but other elements of evidence-based medicine are clinical judgment, patient values, and that sweet spot of evidence-based medicine is where everything meets. So again, I'll be emphasizing the science, but clinical judgment, example of that is, let's say the patient is on other medications and the preferred medication for a given condition ends up potentially either counteracting or not working in harmony with the medications that are already on, or potentially exasperating, excuse me, clinical conditions that are also already there. And then patient values are a real big one. So example of that is, let's say maybe I decline treatment for maybe cancer due to my own personal values, or because of my personal assessment of the trade-offs for the strengths and weaknesses of going down that path. So let's have a little bit of history, since history is always something that we always want to get into. And back in the not so great old days, bloodletting was a therapy for a lot of diseases. Probably wasn't that effective in most cases. Then during the same time periods, roughly, we also had scurvy. You might have heard of the limeys for the sailors. That was resolved. Scurvy was resolved with lemons or oranges, meaning basically vitamin C. And that was reported by Lind, 1753. But that particular treatment has stood the test of time. So the question is, which diagnostic tests are we going to be using that stand the test of time, as well as treatments like these that we just talked about? So that's where evidence-based medicine is valued. So again, my highly selective and condensed history of medicine. Back in the 19th and 20th century, Germans were the ones that were in the lead in terms of medical school training, because they integrated clinical and research training. And there were a lot of big names that many of you probably heard. Albert Schweitzer, who was a great physician, as well as being a humanitarian. There's Virchow, who was the father of pathology, and also had a number of other talents. There was Koch, who discovered TB, cholera, anthrax, and for whom you know about Koch's postulates, and many others. So back in that time, if you wanted a good doctor and you were in the United States, what you want to do is get somebody that was trained in Germany, or even better yet, go to Germany for treatment. Now that all changed back in 1910, and there was the Flexner Report. What that did was that ended up setting certain standards for medical training in the United States. And that ended up being an end to a lot of the non-university based schools. And that's where universities like Johns Hopkins, Harvard, and the like ended up developing their medical programs and starting to train doctors. And that ended up leading to the United States having much better medical care. Some will say we've been leaders for a long time. But even back then, there's a guy named Ernest Codman that I read some of his work. I think as far back as 1912, he was a surgeon in the Boston area. And he didn't win a lot of fans because even back then he was saying, hey, everybody's kind of doing their own thing. Some things work, some things don't. We need to have better standards. So he was really big on having more efficient medical treatment and therapies, and having more consistency. So jumping ahead in my highly selective history here into the 1980s, there was a guy named David Eddy who spoke quite a bit about errors in clinical decision making. Had a strong influence on a lot of clinical history, or how people approach things medicine. There was David Sackett, one of my personal favorites who had a big influence on me, how to apply epidemiological methods in the clinical practice and train physicians into using epidemiological methods. Then there was the RAND health insurance experiment from 74 to 82, and that was funded by the United States Department of Health, Education, and Welfare. So it was an insurance program, and what they were doing were looking at better ways of cost sharing, comparing different groups. It was randomized control, randomized trials, and that's how they randomly assigned different people different insurance plans. And so what they wanted to do is they were trying to figure out, where should we be applying our medical care best, and where can we use it where it's needed, as opposed to sometimes where maybe it's by personal whim, in terms of using these medical resources. At that time, we also had professional guidelines starting to be developed for various conditions, such as professional societies like the American Cancer Society, American Heart Association, and many others. So jumping up to the 90s, there's the Cochrane collaboration, which again is one of my favorites. And what they did was they set up systematic reviews and guidelines, with the idea being that we wanted healthcare that was evidence-informed. It was effective and sustainable, but again, that big word, transparent, and in terms of what is it that what is the evidence, what's the research behind it, why are we saying X, Y, or Z, and a certain part of that transparency is also depending on non-commercial funding, so that even though drug companies or others have the money to support a lot of this research, there's strong potential for bias in those situations. The Cochrane collaboration has been successful enough that the World Health Organization has adopted them as a partner for a lot of their decision-making processes. There were other processes that were developed in the 90s as well, such as out of Oxford, and then GRADE, the grading of recommendations, assessment, development, and evaluation for looking at research studies. GRADE was actually ended up being adopted and incorporated into Cochrane, as we'll be talking a little bit about. One aside that I will mention, I'm not saying anything one way or another in terms of pros or cons about socialized medicine, but one of the benefits of socialized medicine is that you do have these large centralized databases that are perfect for evaluating the diagnostic and treatment selections that clinicians make and the outcomes. And as a consequence, some of the leaders in evidence-based medicine seem to be concentrated in those countries with socialized medicine. And again, I'm not pushing it one way or another, but basically pointing out that it is a fact. So anyway, let's get back to the definition. As we talked about, what's important is that we're being transparent, we're being clear. Also, a reminder that we're looking at not only the research, as I'll be pounding in a little bit later, but again, the patient values and the clinical experience of the clinician are important. The strategy is also how do we incorporate this high quality research on a more regular basis, kind of a lot like what Ernest Codman was talking about over 100 years ago. There's also there's a need for some skills. There are some strategies for how to incorporate the clinical literature into a given case. And you also always want to be raising the bar. Not only do you want to be always learning, but you hopefully research is always progressing, and we're also going to hopefully have the advantage of systematic reviews, meta-analyses, other critical analyses that help us along the process here and hopefully progress our medicine so that we're not just doing things like bloodletting that are probably less than effective. So to pound the point in a little bit more, why are we using evidence-based medicine? We're looking for improved outcomes. We're looking for cost effectiveness. And then again, as I may not have made clear, we're interested in diagnostic methods, prognosis for given conditions, and treatment. So I may blur the boundaries between these, but just keep in mind that they're all part of evidence-based medicine and all targets for improving what we do and how we do it. So how do we get there? Dawes summarized this in 2005, the 5 steps of evidence-based medicine. So one is to translate uncertainty into an answerable question. So an example of that would be, what are the odds of success with one treatment versus another? What is the survivorship? How long can we expect somebody to survive with a given condition? So a lot of that gets back to the critical questions that we ask and looking at the literature in terms of the study design and how confident we are in the results. As I mentioned a few minutes ago, there is a strategy for making sure you get the best evidence available and using those tools, and then critically appraising the evidence. So you're looking at the internal validity, meaning in terms of the study itself, the cause and effect. Is that evident? Is there a strong association between cause and effect based on the research design? Is it clinically relevant? So as an example, I've done some research where we came up with statistically significant results, but clinically, the reference ranges that we were looking at or the values were within the reference range. So clinically, it really wasn't of much value and wasn't of much applicability. Looking for different errors such as selection bias. Are you selecting only people from a different economic group or racial group? Is there a large enough effect size that we can feel confident in the results? And then getting back to validity, there's also external validity, meaning are the research findings that we have applicable to the larger population in general? So maybe certain results are good in one country, but maybe in a different country with different genetics and culture, diet and other cultural practices, maybe things aren't quite so applicable. And we always want to be evaluating performance, critically evaluating how things are going. Are we still on the right path? Are things still working? And then again, as a part of the evidence-based medicine strategy for a clinician, one of the recommendations, they also keep a log of what they're doing and the concepts that they're asking, and as a way of quality control and mapping how things are coming along. So let's skip to the types of studies, and this is what I'm going to be emphasizing a bit for this talk. And as I've alluded to, and unfortunately my cursor is not coming up, but I'm sure you can look at the arrow and see that there are studies that you're not going to have a lot of confidence in, and then there are studies that will have a bit more confidence in the evidence. And a lot of you may have seen this, these types of things, but I'm going to go over it anyway, just to kind of burn it into your brain. But the lowest level of confidence is somebody's editorial or opinion, basic ideas, basically saying, hey, I think this works, but until we have data to support it, it's not going to be one of those things that we incorporate in evidence-based medicine as having a lot of confidence. So going up with a little bit more confidence, we can have a case report, kind of like the first scenario that we talked about, where, hey, this patient got better with penicillin. Maybe it works. Better yet, a case series where there's a series of individuals that got better on penicillin. Next, there are cross-sectional studies where we're looking at a population at one specific time, seeing whether, comparing whatever outcomes of interest that we have. Next, there's case controls, meaning we have individuals that are cases that have the condition that we're interested in, and then the controls, those that aren't. And we're going to be trying to match them based on age and where they live, all that sort of thing. Next level of confidence are cohort studies. A little bit like, excuse me, cohort studies are more of a longitudinal study following populations over time and looking at cohorts that have something in common. Again, you know, whether it be the condition, the age, whatever confounding factors may be of interest. Then we have randomized clinical trials that, you know, everybody is, you know, knows is kind of what we're shooting for a lot of times. Ideally, the patient and those involved in the trial are blinded, so it's a double-blinded study. So that gives us the most confidence in a controlled setting. But what if we have different controlled trials that come to different conclusions and have different results? So that's where a systematic review comes into play. That's a little bit about what I was talking about with Cochrane, where there's a method and a madness that's consistent for evaluating these studies and hopefully making out some good conclusions and weeding out exactly what it is that what the results that are available have. Or even better yet, if we can combine multiple studies results to have a much larger sample size in a meta-analysis, then that's a way we can have even more confidence potentially in the results. Now, nothing's 100%, of course, but again, went from lowest to highest level of influence with these different types of studies. So why is this important? What do we do with it? Well, then we can go ahead and classify the confidence that we have in study results by categories such as level 1, where there's at least one high quality randomized clinical trial that you can hang your hat on for your results. Then there's level 2, and there's several sub-levels within there. There you have controlled trials with some randomization. And then next level down is we have cohort or case control. Ideally, we have more than one center involved. One other case for that level is if we have really dramatic results in uncontrolled clinical trials, that would fall in that category. Then there's level 2, where there's multiple time series studies. And then level 3, which is opinions. So ideally, if you're a patient or if you're a clinician making a decision, hopefully you're working with evidence that is level 1 confidence of your data there. So let's talk a little bit more about systematic reviews. You need to have some input into those systematic reviews. One, as I've kind of alluded to, you have observational studies, or one potential input, but they tend to have a high risk of bias just because you're not necessarily understanding all the factors that are involved with that particular study. And then, of course, as I mentioned earlier, the randomized clinical trials, which have a lower risk of bias, but aren't without bias, aren't completely without bias. So what Cochrane has done is they've set up a system for increasing the rigor. They've got various methods, excuse me here, methods for assessing different studies as a part of these systematic reviews. And they also have some software that helps work you through the process if you choose to use it. And what the process there is that when a group or a panel of people, professionals, look at different studies, what they do is subjectively assess the bias as low, high, or uncertain. And then, that is a judgment call, of course. And then, of course, there are different sources of bias that we'll be talking about a little bit later here. Um, some of them are the allocation. So is everybody randomly allocated? Or are you comparing different populations, maybe different incomes, different geographic areas, different cultures, things of that nature? Again, as I talked about earlier, blinding is good. So then both the participants, ideally, and the researchers, when they make their assessments of either what they think the results are from either the researcher or the clinician or the patient's viewpoint, they aren't biased by whether they think they got the treatment, the placebo effect that maybe some of you have heard, then maybe, and many other risks of bias as well. And then, as I think I alluded to earlier, one of the nice things about Cochrane is they also provide a way of doing meta-analyses. Then you can use statistics to have a little bit better feel for the confidence that you can have in the results of that analysis. So as I mentioned before, GRADE was originally developed independently of Cochrane, but then was incorporated as a part of assessing studies. So going in a little bit more detail of what we were just talking about. Again, the goal here is, even though this is subjective, a subjective process, and there really isn't a good strategy, at least that I've seen, where you can just look at a study and come up with a number that's very objective and reproducible. To classify, your confidence in a study. So it's very transparent, and again, it's a way of being upfront about what is being done. Now, there are different ways of modifying based on the study designs that we talked about earlier, in terms of increasing the confidence that you may have in that study design. And then this reference here is something you can find on the web from the British Medical Journal. But anyway, you can increase the rating for a given study, even though it may be, something like a cohort study that's maybe not really rated quite as high as a randomized clinical trial. But if you're able to demonstrate a dose response, a really huge effect, something like that, GRADE allows for that and allows you to increase your confidence in the results for that. Then there's also criteria for downgrading studies as well. So if there's a lot of range, a lot of, there's not a real precise estimate. So as an example, in the studies, what you're going to see is the standard deviation, coefficient of variation, the range, things like that tell you that there's a lot of variation. So if you're making a judgment for a given test or a given treatment, the outcome is going to be a lot iffy. There's going to be some people that are going to do really well, or that you'll have a lot of confidence in the test results, and others not so much. Indirectness is another one of their categories. And the way I look at this is that a lot of times we study what we can rather than what we really need to. So as an example, let's say we're concerned about how effective a medication is for preventing bone fracture in the elderly. So let's say we don't have a lot of time, we don't have a lot of money. So maybe what we do is we use bone density as a proxy for our the real question, which is the risk of fracture over a given period of time. And so the risk of fracture over 5-10 years is probably a better study for addressing that. Another example in today's day and age is if you were to compare last August with all the August before that for the last 10 years, and you looked at all-cause mortality, and it was increased, is that a reasonable proxy for the effects of COVID-19? Or do we need to maybe look at tests results that are a little bit quicker to obtain, maybe in some way, but the trade-off there is that maybe we're not as confident in a lot of these tests that have been rushed out to market pretty quickly. Inconsistency. So as I mentioned a little bit earlier, if there's a lot of variability within a study or across studies, that gives you less confidence in the results, and maybe you're going to think a little bit more about what path you're going to go down in terms of addressing a given condition. Then there's publication bias. Excuse me. And probably the biggest thing there is non-publication bias, because traditionally what gets published is significant results, but if you have a non-significant result, that can potentially be a value as well in terms of having a feel for how much confidence you can have in a given treatment or diagnostic test. And those may not make it into the press. And as a consequence, it's harder to find information and have a more unbiased assessment of what path you want to go down. So what Gray does is they end up classifying things as high quality evidence, which is basically that there's a low probability that future research is going to change your conclusions. Moderate quality evidence, where maybe you're not quite as confident in the results, and maybe you're going to change your opinion at some point. There's low quality evidence where you really don't have a lot of confidence, and it's very likely that new results are going to change your opinion. And very low quality evidence is the next category, where it's probably not much better than a case report, and you may or may not have, it may or may not be of any value, and it may not influence what decisions you make. So as I told you, I really got into the Cochrane systematic approach, but there are other methods. So the U.S. Preventive Services Health Task Force also came up with a way of classifying research. They have level A, in which basically the evidence is that the good far outweighs the risks if you're going down a different path. There's B, where maybe not quite so strong, and you're going to kind of question a little bit, think about it maybe a little bit more. There's level C, where the balance between the benefits and the risks is pretty close. So there, particularly, you're going to be pulling in a lot of the ancillary evidence to decide how to go down a path. Then there's level D, where the risk outweighs the benefit. Examples of that may be, I remember there have been periods of time where medicine has been imported from overseas, and maybe it wasn't, the benefits were questionable, and maybe there were a lot of contaminants, such as mercury or other things that even if there was some benefit, maybe the risks far outweigh those benefits. Then there's also level I, where the evidence is kind of uncertain in terms of how you should proceed in terms of a given clinical strategy. So as I mentioned earlier, evidence-based medicine is not the holy grail. There are some criticisms. One is that the demand for evidence-based medicine far exceeds the supply. The amount of funding and other resources that are needed to conduct these sorts of studies is limited, and the number of conditions where we'd really like to have these evidence-based medicine strategies is fairly limited in terms of where you can go ahead, and you have to be selective, or you have to have other reasons why you want to go are able to apply these resources to a given question. Randomized trials may not always be of value, as I mentioned. There can be different ethnic groups, different cultural, socioeconomic, environmental factors. So, for people like me that have a strong interest in epidemiology, we kind of look at the real world as our metric for how well some of these things work. But that's not to discount randomized clinical trials as a starting point for a lot of these things. As we mentioned earlier, there's publication bias, either because of what is published and what is not. And then there's also who's supporting these studies and potential conflicts of interest there because of industry. There's a lag time. As most of you know, it's usually at least a year or two before research is published. So there's that year or two where you have a certain finding, you're not able to apply it in the real world. And that's been sped up a little bit with COVID, but the trade-off there is that some of the stuff that's coming out is probably not going to stand up over time, and will go by the wayside as more information comes in. Patient values. That's always a really tough one, at least in my mind, for incorporating, because you never know what somebody's personal values are, what their history is, what other family members have gone through, friends. All those sorts of things influence what a patient chooses in terms of what's best for their particular situation. Then there's hypocognition, where basically there's not a framework for incorporating new information. So my favorite example for that is many of you have probably heard of mad cow disease from a decade ago, Jakob Creutzfeldt disease, and scrapie, and many other diseases that for a long time it wasn't sure what the source was, but then the prion hypothesis and came up, which is basically it was an infectious protein, not a bacteria, not a fungus, not a virus, not the usual things that we think of as infective particles, but a protein. And I'm drawing a blank on who won the Nobel Prize for that. But basically we didn't have the framework to think of proteins as being infectious. So that's an example of hypocognition. So in summary, again, I'll remind you, even though I emphasize study design, because that's something that each of you have some capacity to use, either for yourself or in other settings, particularly if you're a clinician. There is the issue of clinical judgment, which, as we talked about with the medical school training, we're always trying to train that, but it's always hard to make the perfect clinician that can handle every situation and assess all the information correctly. And again, patient values is an important part of the equation. Updating systematic reviews and various guidelines, and continuing to do the research and keeping up to date are all important. And then also continuing to use strategies for, in a clinical setting, to continue to question what you're doing and try to improve, and hopefully have better outcomes as time goes along. So I think we're reaching the end here, and if there are any questions, hopefully there's people still out there. I have no way of seeing whether people are awake or anything, but I look forward to hearing from you.
Yeah, so if you have any questions for Dr. Miller, please feel free to put it in the Q&A box or put it in the chat. But I guess just to start us off this, how do you balance the science, the clinical judgment, and then the patient values?
Good question. It's going to be very situational. It's going to depend on the patients and the physician and their particular interactions. As I mentioned a few seconds ago, it depends on the training, how committed the clinician is to um, taking in new research and applying these evidence-based medicine, evidence-based approaches, and also how much the clinician is open to changing. So I guess one of the examples I can think of for that was I read studies from the 90s where chlorhexidine was, for a number of reasons, for many situations, was preferred antiseptic for skin for many uses. And then just a couple of years ago, I heard a human ER physician giving a talk where he was begging people to switch from the iodine products to chlorhexidine in most products. And again, maybe beating the drum a little um, too hard, but there's that key to really understanding the personal values, what's important to a given situation, and being able to get the patient involved and sharing what's important to them, what their biases and concerns are.
Awesome. Is there a difference between how industry and clinicians use evidence-based medicine?
That's an interesting question, and hopefully brings kind of a more real-world twist to the what was kind of more of a theoretical question. I guess for clinicians, I get back to the 5 steps of evidence-based medicine slide where you're looking at for answerable questions, using the tools that you have to get the literature and evaluate it, apply it, and then just critically evaluating, is it working, and really having that commitment to continuing education, applying these tools. From an industry standpoint, for those of you that maybe are interested in developing various tools, keep in mind that, maybe keeping these concepts in mind when you're developing tools for clinicians. And then in terms of the products that you're developing, whether it be medicine, a diagnostic test, something else, do the quality research. Have some transparency in terms of presenting the outcomes for the results and how you got to those results, and then effectively communicating those results as well.
So how can someone learn more about the Cochrane collaboration?
They have a website under the Cochrane collaboration. As I recall, there's also other websites. I think even Wikipedia, I looked at a few years ago, had a nice summary. So depending on the questions that you're interested in, you can do a web search for evidence-based medicine in general, as going a little beyond that question. And that's a way of also learning about different opportunities for training and continuing education. Then I also put a plug in for, I'll be giving a talk in a few weeks on clinical epidemiology. That has some relevance to evidence-based medicine as well. So make sure you sign up for that.